Because the main aromatase inhibitor side effects are osteoporosis and dyslipidemia, statins and vitamin D supplements are frequently co-administered alongside the antiestrogenic treatments. But aromatase inhibitors, statins, and vitamin D efficacy and side effects are highly influenced by each patient's adiposity level. So, does this common clinical practice have scientific arguments behind it? The current scientific data addressing the efficacy of vitamin D and statins in preventing osteoporosis and cardiovascular disease show that taking vitamin D supplements for cardiovascular protection, for cancer prevention, or osteoporosis in patients without vitamin D deficiency has no proven clinical utility, and that lowered LDL cholesterol associates surprisingly small gains in overall survival, the median postponement of death in primary and secondary prevention trials being of only 3.2 and 4.1 days, respectively. And this minimal impact statins have on overall survival, it's not about statins being able or not to decrease LDL cholesterol. This low impact on overall survival is based on the fact that the cardiovascular risk itself is plurifactorial. Obesity, sedentariness, smoking, insufficient or low quality sleep, stress, anger, anxiety, and depression, all increasing cardiovascular risk. Thinking that you can just wipe out all this by simply taking a pill is marketing, not physiology. Still, statins are recommended based on randomized trials showing a 12% reduction in vascular mortality risk per millimole per liter of LDL cholesterol reduction. And in the general population, they're considered quite safe, as it is estimated that the treatment of 10,000 patients for 5 years with 40 milligrams of daily atorvastatin would cause about 5 cases of myopathy. But statins are recommended also to patients with estrogen receptor positive breast cancers under antiestrogenic treatment, despite the fact that both the antiestrogenic treatment and statins have muscular toxicity as a side effect, the double muscular hit associated by the co-administration increasing the myopathy risk. Moreover, in breast cancer patients, the metabolic decrease amplified by statins prosarcopenic effect increased the risk of sarcopenic obesity, leading to more weight gain. And it is true that many breast cancer patients gain weight during treatment, and that this increases recurrence, metastasis, and mortality risk. But studies performed specifically on breast cancer patients under antiestrogenic treatment show that the co-administration of statins to aromatase inhibitors associate increased weight gain and decreased chances to fat loss. For instance, in one of our studies we performed at the Oncology Institute in Bucharest, we randomized breast cancer patients under antiestrogenic treatment, half to the control group with no nutrition intervention beside the physician general recommendation to try to avoid to gain weight, and half to the intervention group based on a moderately higher protein Mediterranean type diet. We measured weight and body composition, and we followed them for 24 months, and then we analyzed results based on the type of oncology treatment and on patients' age, lifestyle, and comorbidities. The study was presented at ESMO Congress in 2018. What we find out is that weight and fat loss in our breast cancer patients under antiestrogenic treatment was not influenced by chemotherapy and radiotherapy administration, by the type of breast surgery, by salpingo-oophorectomy, or by the dieting history of the patients before the breast cancer diagnosis. And this maybe have been the case because this patient received proper oncology nutrition starting diagnosis performed by dietitians with clinical expertise in working with breast cancer patients. And efficacy was influenced by the type of antiestrogenic treatment. Patients on aromatase inhibitors losing more weight and visceral fat than patients on tamoxifen. But although, as a group, patients on aromatase inhibitors obtained better results, those on anastrozole and exemestane with statins co-administration lost less fat. And this can influence this patient's oncologic outcome, as obesity is associated in this patient population with decreased efficacy of antiestrogenic treatment and more side effects, the main impact coming from the fact that these very side effects are one of the main causes of treatment non-adherence and discontinuation, increasing breast cancer-specific mortality. Now, related to vitamin D supplements, despite a few hundred systemic reviews and meta-analysis, evidence of a clear role of vitamin D supplements does not exist for any health outcome unless the patient is first vitamin D deficient. And the D-Health randomized controlled trial, just published in January 2022, shows that administering prophylactically vitamin D supplements monthly to unscreened older people did not reduce all-cause mortality, while point estimates and exploratory analysis, excluding the early follow-up period, were consistent with an increased risk of death from cancer in those taking the vitamin D supplement. It is true that obese patients have lower vitamin blood levels because of its fat deposition, but for the same fat deposition reason, vitamin D supplementation in obese people is less efficient, and levels can go back up to normal without supplements when adiposity decreases back to normal. But what we need to be careful is how these patients lose weight, as systematic reviews of various weight loss interventions show that weight loss intervention non-specific to breast cancer patients under antiestrogenic treatments can induce bone loss, amplifying the already increased risk of osteoporosis. Breast cancer patients don't have to lose weight for the sake of weight loss. To improve prognosis, they must lose fat without losing muscle. And if breast cancer patients just lose weight by dehydration, muscle, or bone loss, they'll only obtain worsened sarcopenic obesity associated with worsened cardiovascular and osteoporosis risk. In conclusion, statins and vitamin D supplements alone do not decrease cardiovascular or osteoporosis risk in obese breast cancer patients under antiestrogenic treatment. And because of the negative metabolic impact of improper diets, weight loss in these patients should be carefully designed and monitored by a dietitian with high clinical expertise in oncology nutrition. Thank you.